variety of different reasons. We'll talk about some of the major ones here in a few moments. We've made some significant progress in the last 10 years or so. For example, we've been able to decrease the risk of individuals coming down with cancer in those areas by about 3% per year per group over that time frame. So we've been able to make some progress.
Hi. Sorry.
And that's across both genders and multiple racial groups. So this is a good thing. Obviously, and most of us have had family members who have succumbed to these diseases sometime during our lifetime, and it's a tragedy for the individuals themselves, obviously, for their family, for the community as a whole, because it costs money. And we're all about saving money these days. So what can we do to help? Thing number one, and the primary risk factor, and one has to understand that when it comes to cancers, you're talking about relative risk. I sometimes liken this to going to Las Vegas and trying your luck against the house. Now, most of us know that it's a rated situation and the house is always going to win. But maybe you find some situation where you come out with more money than you went in with. This is a good thing. Of course, what you realize is the U.S. government and the state of Nevada are going to take their cut before you even leave the house. But hopefully you win something. That's the whole idea. And we can help you to win in this battle against cancer, in the lungs and in the colon and in other places, with some things that are fairly simple, with some things that aren't so simple. The number one risk factor, the number one thing that puts the odds against your favor, against you winning against cancer, is smoking. Now, I had the privilege of talking with one of your number before we started, and she was relating to me how difficult it is to get her spouse to quit smoking. That several of your members did. And I'm sure most of you have that story or say, gosh, it was a real battle for me to quit smoking. Because if you think about it, if so overall you introduce tobacco now, it would be a Schedule I drug. It would be even more addicting than heroin. And most of you who have been smokers or are kind of know that. So it's a very difficult thing to quit once you've started. It can be done. Most smokers take about 7 tries before they're finally successful. But we have aids to help people do that. There are non-prescription products out there. There are prescription products out there. And again, every individual who says, gosh, I really want to quit this. This was a silly teenage thing that I started years ago, and now I realize it is silly and I don't want to stop doing it. But your physician has tools to help you. And again, your best bet is to discuss that with them at some length and see what tool could work best for you. But knowing that it is probably one of the biggest struggles that most adults can have in their life, is to rid themselves of that burden, of that risk to their life from cancer. Some of the other things that we've done as a community that have helped, screening tests. For example, back when you and I were young, it was very common to have mass screenings of chest x-rays to see if people had cancer. We don't do that anymore. But that may come back. There's some discussion among the doctors about, in certain populations, for example, people that are over 60, or people who have a history of tobacco abuse, might that kind of screening activity be cost-effective and useful? So we'll see if that comes about. Regular checkups. Most, with the newer insurance plans, that they're encouraging you to do that sort of thing, and you get rewards through your insurance plan to that end. And even very young adults can benefit from that. So certainly, if your plan offers that option to you, I certainly would try to do that. Better diet. Now, certainly, unfortunately, in the United States and here in Pennsylvania, we're probably the goodie capital of the world. If you want snack foods, they're widely available, and some of us are more prone to those snack foods than others. But particularly among our younger adults now, they're better educated than we were. And they're realizing that, gosh, that's just really not a smart thing to be drinking all the soda pop and eating all the snacks and so on. So they're consumption of that sort of thing is less as a group than among the older generations. And even we're getting a little hip to that sort of thing. So diets that are lower in carbohydrates, the snack foods, higher in fiber, this kind of thing, can significantly improve your odds of not having cancer, particularly in the colon. Now, there are unfortunately a lot of fads, and you see those mostly on television. If you take this particular vitamin or this particular product, or you go to our particular clinic, why, your risk of cancer will go away. That's muffins. And most of us have enough common sense to realize that. Unfortunately, there's an awful lot of people out there who spend an awful lot of money on fads and gimmicks. And about the only thing it does for them is empty their wallet. And I've had a number of patients over the years say, well, Doc, I heard about this on the internet or that on television, and I really want to try it. And I tell them, well, listen, if you want to try it, hey, fine. But when you find out it doesn't work for you, please come back in and let's try something else and try to help you. And unfortunately, inevitably, they always do. So there's a lot of tools out there. And again, you can discuss this with your own physician at your own convenience. And look at some of the tools that are out there. Certainly the two top two groups of that, stopping smoking. Number two, doing screening tests of whatever nature. Now, the people will ask the question, well, gosh, Doc, what if my spouse smokes? What if my girlfriend, boyfriend, whatever they are? What if my children smoke? But they go outside, or they don't smoke in the car. Those are the two most common things that we hear. Unfortunately, the cancerous leading products that are in tobacco smoke will settle on their clothing, their hair, or what have you. And you're going to have to breathe that in while you're sitting next to them or lying next to them or whatever. And it's going to be on their clothing. You've opened, I'm sure most of you have been with a smoker, opened the closet, and it smells like an old ashtray. But a lot of those nasty things that you smell are potentially cancer-causing. So again, another incentive for that individual to say, hey, listen, let's try to kick the habit and move on. So the so-called passive smoker, the person that's married to someone who's a smoker or lives with them or whatever the situation is at somewhat higher risk than someone who doesn't have that exposure. I always tell people, if you went to a manufacturing plant and went to their tall chimney and stuck your head in there and breathed that stuff up, that's what the risk of smoking does to you. It's pretty much about the same. So let's hope that we can continue that battle. And it's a battle worth fighting, I think. Because I see so many individuals who suffer the tragedy of cancer. And if we can help you avoid it, if we can help your family avoid it, then that's good for you, and that's what I want. Don't take this wrong, but I don't want to see you in the office. Not for that. So we talked about things that we can do to help decrease your risk, help put the odds more in your favor. Smoking cessation, screening programs, better diet, those kinds of things. And you say, well, gosh, then, Doc, what happens if, God forbid, I'm a non-smoker, but my doctor just found out I have lung cancer? I was discussing with a colleague of mine this morning before we came over. Her patient is about your age, unfortunately, and she has it all spread all through her lungs and probably all through a bunch of other places. Now, we'll help her where we can. But again, there's some hope in that area. It used to be, when I was a small boy, that if you were diagnosed with lung cancer, you were diagnosed with colon cancer, it was a death sentence. You were going to die in a horrible fashion. There are now a number of tools. For example, now again, to some extent, this gets back to the screening process. Say, well, how can you screen for colon cancer? The way you do that is at a certain age. Your doctor might say, well, you know, you're at the age now where, and because of smoking exposure or whatever your other risk factors are, you know, you probably should have what's called a colonoscopy. A colonoscopy is taking a bendable tube about as big around as my finger. And once you've been anesthetized previously, the doctor takes that tube, lubricates it, puts it up through your bum, and goes, you had one of those? I've had several. You've had some? Mine were okay. I don't know how you experienced.
Mine was excellent.
Right.
Mine?
Right. In the old days, they did that with a rigid scope. And they didn't put you to sleep, so you can imagine how hard that was. But those days are long gone. Thank God. Yeah, your turn's done. So if your doctor recommends that, that's a smart thing. And again, helps as far as discounts on your health insurance and this sort of thing. And the advantage to that is the doctor, and they put it in their left hand in case you're curious, because that's just the way it's built. But they will look through the scope, or they'll have a TV monitor sitting there, and they're advancing the scope and looking at the monitor. And if they see something that looks funky, and unfortunately I don't have an audio visual to show you, but if you can, most of you have, particularly if you're mature, probably have a little skin tag somewhere on your neck or your other parts of your body. And that's kind of what it looks like. And it shouldn't be there. Most of them are not cancers, so that's good. But the doctor, certainly if they see that, they'll remove it. And they won't cut out a piece of your bowel to remove it. They have little, looks like a little snare sort of thing. And they'll go through the scope and take care of that and remove it. And not only will they remove it, but they'll send it to the lab. And the doctor there will look at it to see if there's any cancer present. And then they'll send a report back to one way or the other. But certainly, as I say, as you get into your mature years, and notice I didn't ever say older, I say mature. Yeah. If you get into your mature years and your physician says, gosh, you probably should have a screening colonoscopy, by all means, let them set that up for you.
They gave you pictures.
Yeah, they usually give you nice color photos. And,
Yeah,
ooh, that looks terrible. It's really not that bad. The only hard part for most of us is the fact that you have to clean out your bowels for a day or two beforehand. You're nodding your head, so that was not fun, because you got to know your toilet very well, as we all do. But I think it's worth the hassle. All of us in our work life, we have things like, you go to some meeting and you probably call it a dog and pony show or something like that, because it's a senseless nonsense meeting. And you say, I should be bored. But you have to do it for whatever reason. It's part of your job. So you just, okay, put up with it. So the colonoscopy is kind of like that. It's, to some extent, the preparation is not a whole lot of fun. But in the long run, if it saves you, if it saves your family misery, then that's certainly something worthwhile. But let's say, for example, that, oh my gosh, the doctor took out one of my polyps and it was cancerous. Is this the end of my life? The answer is no. First of all, he removed, or she removed the polyp, so they removed the cancer. Now, they'll do other studies as a follow-up to that, if in fact it was cancerous, to see if they, quote, got it all. Okay? And they'll probably do a series of colonoscopies for you. They'll probably do a series of biopsies. They'll take little tissue samples of the colon wall and see what they find. And then they'll sit down with you and make a recommendation. Gosh, partner, we probably should do the next step. Now, in the old days, if they had to remove a piece of the colon, they would make a great big surgical scar from the front up to your belly button and sometimes beyond. And it was horrible, and it took a long time to heal, and you were off work, and it was miserable. And you were miserable. And sometimes they would actually put the colon out to the abdominal wall. You've probably seen people like that. And that's certainly a miserable experience. But in the last few years, through that same colonoscope, they now have tools that they can remove pieces of the colon and staple the other two pieces, the other two ends back together again through the scope. So in a lot of cases, not all cases, but in a lot of cases, no big surgical scar, no colostomy bag, none of that stuff. And in fact, the latest version is that a lot of these things are not done by the physician holding the scope. They're done by the so-called surgical robots, which you may have heard about. If there's, as tragic as war is, those of us who have done it never enjoyed it, but if there's any good to come out of that, it's things like the surgical robots. That's where they were first used, was in surgical theaters, in remote places. That way you could have the surgeon take care of an individual and then just turn around without all the hassle of physically going to where this next patient was and make the appropriate connections and then be able to operate on them and get them taken care of. So those kinds of tools are out there. And again, that's something that you'll discuss with your physician and your surgeon at some length. And I tell people, always ask questions. A lot of folks come in and they'll have a printout from WebMD or please don't go to WebMD, it's terrible. No, but or some site on the internet. Some of what's there is relevant to you. A lot of it's not. And it's a job between you and your physician to figure out what's relevant and what's useful, what can help you feel better about what's going on. So bring that stuff if you want to, and if you want to highlight and that sort of thing, hey, great. Ask questions. Okay? There's no such thing as a stupid question. There's a question that's unasked that scares you or scares your family. That's stupid. Okay? And if you and your physician work together as a team, it's going to benefit you in the long run. So like I say, if you have questions, ask at the appropriate moment. When you're getting ready to get on the table for a colonoscopy, it's probably not the time to ask the question. I've had people do that. But take the right opportunity and be comfortable with whatever's going on. What are your options? Where do you want to go? Those kind of things. With lung cancer, again, much the same technology exists. The surgical robot, and the in this case it's called bronchoscope, but it's the same thing. Bendable tube about as big around as your finger, goes down the throat into the lung, and the doctor takes pictures, and will probably give you a couple of souvenirs, and they could remove whatever the lump is. Now I apologize for our audio visuals, but they are what they are. If one took a lung sample, and I'm not suggesting you do that, of a very young adult who's a non-smoker, chances are, if you did, this is pretty much what it would look like: nice and pink tissue, air spaces, big blood vessels, all that kind of thing. Unfortunately, the individual who has developed a lung cancer, that's what their biopsy would look like. And pardon, the unfortunate individuals are the ones that have not just one lung, but have a whole bunch of lungs. And that's the lady I was telling you about that we're dealing with this morning. Pardon me. But even within some reasonable limits, the doctor can use the bronchoscope, go down and get all or most of this lump if there's just one. Now, just because you have a lung lump doesn't mean it's necessarily cancer. In large parts of the world, and certainly even in the United States, a lot of people have been exposed to other things, mostly a fungus of some sort or another. You may have heard of something called San Joaquin Valley fever, something that it basically seems like a cold that is very common in that part of California, or Ohio Valley fever for people who live in that region, and people who live in or near farms, because they're exposed to all the stuff that's in the silos and around the animals and so on. Not terribly uncommon for those people to have small fungal infections in their lungs. It never really bothers them unless they develop other health problems. And they show up as a lump on their chest x-ray, and they get biopsied through the bronchoscope. It doesn't quite look like this. It looks small and hard and whitish. But find out what it is. And they say, oh gosh, it was just due to a fungal infection. It's an old mass. It's never going to go anywhere. Then you've won. The odds have been put in your favor, and you just won at blackjack, and you just took away $500,000. Good for you. Okay? You scored the home run. That's what we want. Okay? So just because the doctor says, gosh, there's a polyp, there's a lump, doesn't mean A, it's cancer. It doesn't mean B, it's the end of your life. It's, I say there's a lot of these are not cancerous. And the way to find out is to say, hey, doc, are we going to biopsy? Oh, yeah, we plan the biopsy. It's going to be on this date. And y'all work it out and proceed accordingly. Okay. And it's always good, if you're going to have that conversation, to have someone that you're close to, your spouse, your sister, whoever, with you, so that they're okay with what's going to happen. And saying, all right, you're going to go in and have the biopsy done. You're going to come home that afternoon, unless there's some unforeseen complication. And you're going to go to work the next day, and you're going to be fine. And then the doctor will call you later and say, hey, this is what we found. So the odds, again, the whole purpose of the program, the whole function of the program is to put the odds more in your favor so that you do well. Okay? So they do the biopsy, they find out what it is, and they tell you. And they might say, gosh, just because of your risk factors, getting older, being exposed to a smoker, those kinds of things, that we probably should at least do a chest x-ray and some other studies in a year or 6 months or whatever the recommendation is. And the intelligent person says, gosh, I'm going to do that. And they'll go ahead, and again, the idea is to put the odds more in your favor so that you live to a ripe old age and have a fun life and a good life. That's what we're aiming for. Okay. So, hopefully, your lung never looks like this. Your colon never, I'm sorry I don't have a colon here to show you. Your colon never looks like that. The healthier lifestyles that we talked about will put the odds much more in your favor of avoiding this. Working with your doctor as a team, and again, this is one of the things you emphasize here as a business, is everybody working as a team, getting the whole thing done so that we all make it, right? And that is the object of the game, right? But that we all kind of enjoy our work and we kind of enjoy working together, sort of, kind of. But we do good things. Your company just won a multi-million-dollar contract, I understand, to build new vehicles for the military, and they'll probably build them for other people too. Good. And everybody will profit from that. But to do that, everybody's going to have to work together as a team, and you all already know that. You do that anyway. So this is kind of the same idea, that you work together as a team with your physician or multiple physicians and your family, your friends, to try to make your outcome good. That's what we're going to aim for. If you need a biopsy, me personally, I would proceed with that. If they say, gosh, we need to then go in and remove this lump or some other kind of a thing, I would probably proceed with that. Now, the next question is, Doc, what about this lady that you were talking about that has multiple lumps everywhere, who probably cannot have them all removed? What's available? I mean, do you just tell her, go home and die? No, and the answer to that is no. Particularly in the last 10 or 15 years, a whole bunch of new tools have become available. Some of you have heard about a hospice-type operation. And hospices is usually a community-based medical operation, and it's designed to help people who have essentially an untreatable medical condition that's going to end their life very shortly. We say normally within 6 months. The two emphases in any hospice operation is the quality of life for the individual within reason, and the dignity of the individual, and as part of that, ensuring that they have adequate pain control if they have to, that their breathing is as easy as it can be under the circumstances. And the majority of the effort in most hospice operations are geared towards not so much helping the person, they do that of course, but their family needs as much or more help than they do. So helping them with the various, how that person's cancer or their other condition impacts their lives. And we just had a lady that had a very bad condition. Her family was kind of at odds, and our hospice folks came in, provided them quite a bit of help in terms of their emotional problems and some of their logistical problems, and made her end much more dignified. So it's certainly a tool that can be used in that event. So all that sounds bad, but there is hope, and that's what we were trying to promote as much as we can. Does anybody have questions at this point? Okay, thanks for your time. Did I go a little over? About right?
You're good.
Okay.